What the study says.
Welcome to the Deep Dive. Today, we're tackling something nearly everyone bumps into at some point. Dizziness. That really strange kind of unsettling feeling. But here's the catch. Dizziness isn't just one thing. It's sort of an umbrella term for a lot of different sensations, and figuring out the cause, well, that's surprisingly complicated.
It really is complex. And, our sources point out that dizziness is one of the top reasons people end up going to the doctor.
Wow.
Yeah, and nailing down why it's happening is so important because the causes range from something pretty minor, maybe just annoying, to potentially quite serious.
Absolutely. And for this deep dive, we've gathered a bunch of recent medical reviews, clinical guidelines. Think publications like the American Journal of Medicine, Up to Date. Basically the latest thinking on dizziness and vertigo.
Right. And our goal here is to unpack all that medical info, cut through the jargon, and give you a much clearer picture. We want to talk about what these different sensations actually feel like, explore the huge range of things that can cause them, some might surprise you, and sort of walk through how doctors try to work out what's going on, and crucially, what treatments the research actually supports.
Yeah, we hope you come away understanding this common symptom better, maybe for yourself, maybe for someone you know. Okay, let's dive in. First things first. That basic confusion. Dizziness versus vertigo. What's the difference?
That's definitely where the sources say to start. Because while people might just say, I feel dizzy, medically speaking, there's a distinction we need to make.
Okay.
Dizziness is the, let's say, broader term. The sources describe it as a disturbed sense of your spatial orientation, but without a false sense of motion.
So like feeling unsteady, or maybe lightheaded, woozy, like you might faint, but the world isn't actually moving.
Exactly that. You feel off balance, maybe a bit swimmy-headed, but no illusion of movement. Vertigo, though, that's different.
Right.
Vertigo is specifically the sensation of motion when there isn't any real motion happening, or maybe a distorted feeling of motion when you're moving your head normally.
Ah, that's the classic room spinning feeling people talk about.
Precisely. Either you feel like you're spinning, or you feel like the environment around you is spinning. That's vertigo.
So vertigo is one specific type of dizziness, but you can be dizzy without having vertigo.
You've got it. And because patients often use the terms interchangeably, doctors really have to dig into the description. They'll ask things like, okay, tell me exactly what you feel. Is it spinning? Is it like you're going to pass out? Or more like you're unsteady on your feet? Getting that subjective feeling is absolutely key.
And all of this loops back to our body's amazing balance system, doesn't it?
It really does. We have this dedicated system, the vestibular system. It's incredibly intricate. You've got structures in your inner ear, these little fluid-filled canals and sacs. They connect to nerves, sending signals up to parts of your brain, the brainstem and the cerebellum. And this whole network is working nonstop behind the scenes just to keep you upright, oriented. And it even helps keep your vision stable when your head moves. Like think about looking out the side window of a moving car, how you can still focus on something. Your vestibular system is working with your eyes to make that happen.
It's like this built-in gyroscope and stabilization system.
Yeah, that's a great analogy. And naturally, if something goes wrong anywhere in that system, the inner ear, the nerve pathway, the brain regions, well, that's when you can get these balance problems.
Yeah.
Dizziness, vertigo, maybe even blurry vision, or those jumpy eye movements called nystagmus.
Okay, so it's complex. Problems can pop up in different spots. The sources seem to break down the causes in a helpful way, right?
Yeah, they generally categorize dizziness causes into two big buckets. Vestibular, meaning originating in that balance system,
Okay.
and non-vestibular, which covers other medical issues that mess with your orientation or make you feel faint. And then within the vestibular causes, they split it further into peripheral problems in the inner ear or the nerve itself.
Right.
And central, meaning the problem is higher up, in the brainstem or cerebellum.
Let's start with peripheral then, because the research really highlights one cause as being super common for true vertigo.
Ah, yes, benign paroxysmal positional vertigo. BPPV for short, thankfully.
Right.
And this is what gets really quite interesting, mechanically. The sources explain BPPV happens because these tiny calcium crystals, they're called otoconia, which normally live in one part of your inner ear. They sometimes get dislodged, they break loose, and end up floating around in a different part of the inner ear where this shouldn't be, specifically the semicircular canals.
So little bits of grit basically end up in the wrong place.
Kinda, yeah. These canals are filled with fluid, and they sense when your head rotates. So when you move your head in certain ways, like lying down quickly or tilting your head way back or even just rolling over in bed,
Okay.
these loose crystals get swished around in the canal fluid. And this movement sends a powerful but incorrect signal to your brain saying, whoa, you're spinning dramatically,
Yeah.
even if your head movement was actually pretty small.
Like shaking up a snow globe in your ear canal.
That's a perfect way to think about it. And the key thing the sources stress is that this causes really brief episodes of intense vertigo, usually just seconds, maybe up to a minute or two. And crucially, it's triggered by those specific changes in head position. Usually, there's no hearing loss or other neurological stuff going on, which helps doctors suspect BPPV.
Makes sense. What about other common peripheral causes?
Well, there's acute vestibular neuritis, or sometimes labyrinthitis. This is thought to be an inflammation, probably from a virus, that affects the vestibular nerve that's neuritis. If it affects the hearing parts too, it's called labyrinthitis.
Okay.
This causes sudden, severe, and usually persistent vertigo and imbalance. It can last for days initially, really knocking you off your feet. Most people do recover, but the recovery can sometimes be prolonged.
And Meniere's disease. That one sounds different again.
It is. Meniere's is known for its distinct episodes or attacks. You get recurrent bouts of vertigo, but they last longer than BPPV, typically over 20 minutes, sometimes hours. And importantly, these attacks come along with other ear symptoms: fluctuating hearing loss, ringing in the ear tinnitus, or a feeling of pressure or fullness in that ear. It's a very specific cluster of symptoms.
Okay, shifting gears now to central causes, the one starting in the brain. The sources say stroke is less common than BPPV, but it's something doctors absolutely have to consider.
Absolutely critical. Strokes, especially those affecting the back part of the brainstem or cerebellum, can definitely cause acute severe vertigo. Unlike BPPV, this vertigo is usually persistent, lasting hours or days.
Right.
But a key point from the sources is that having vertigo completely isolated with absolutely no other neurological symptoms, like no trouble walking, no slurred speech, no vision changes, no weakness, that's actually pretty rare for a stroke.
Yeah.
Usually there are other red flags.
But you mentioned there can be a catch with getting images early on.
Yes, that's a really important practical point the sources make. Standard MRI, which is the best imaging test for stroke, might actually miss a small new stroke in the brainstem or cerebellum in the first 24, maybe even 48 hours.
Wow.
Yeah, so that really underlines why the doctor's careful history taking and detailed physical exam are just so vital, especially in those first hours. You can't rely solely on an early scan being negative.
Another central cause you mentioned was vestibular migraine. I think a lot of people just associate migraine with headache.
That's a really common misconception, and the sources help clear it up. Migraine isn't just a headache, it's a complex neurological event. And it absolutely can show up as attacks of dizziness or true vertigo.
Even without a headache.
Sometimes, yes. Or the headache might be mild, or come before or after the dizziness. These vestibular migraine episodes can last anywhere from 5 minutes up to 3 days, and often come with other typical migraine features: sensitivity to light or sound, maybe visual aura. And the sources also mention, interestingly, that having migraines is itself considered a risk factor for vascular issues, an important link there.
Are there other brain-related issues that can cause dizziness?
Yes, definitely. Though often they present with more than just dizziness, usually other persistent neurological signs. Things like multiple sclerosis, certain brain tumors, or structural problems like Chiari malformations where brain tissue is kind of squeezed. Those can cause dizziness or imbalance.
Right.
Also, conditions affecting gait and balance pathways more broadly. Think some types of Parkinsonism or nerve damage, like peripheral neuropathy you might get from B12 deficiency or diabetes. They can lead to unsteadiness and problems with spatial orientation too.
Okay, so that covers the vestibular side, peripheral and central. What about the non-vestibular causes, where it's not really about spinning?
Right, this is another huge category. And a really common one relates to our autonomic nervous system, the system controlling stuff like blood pressure and heart rate automatically.
Ah, like standing up too fast.
Exactly.
Sometimes-
Orthostatic hypotension, OH, is a classic. That's when your blood pressure drops significantly when you stand up from sitting or lying down. It causes that lightheadedness, maybe vision changes, feeling like you're about to faint. And then there's POTS, postural orthostatic tachycardia syndrome. That's related but slightly different. With POTS, your heart rate jumps up excessively when you stand, often causing dizziness and lightheadedness, but usually without that big drop in blood pressure seen in OH.
And the sources really hammered home that medications are a big culprit here.
Oh, absolutely. This is a major, major takeaway. Medication-induced dizziness is incredibly common. So many drug classes can cause it. Blood pressure meds, antidepressants, anti-anxiety drugs, seizure medications. Even some antibiotics can be ototoxic, meaning they directly damage the inner ear structures.
Wow.
The good news, usually, is that this type of dizziness often gets better if the problematic medication can be stopped or switched, which really highlights you always need to review your medication list with your doctor if you develop dizziness.
Definitely good advice. What about dizziness related to neck problems?
Yeah, that's called cervicogenic dizziness.
Oh, yeah.
The thinking is that issues in your neck, maybe arthritis, muscle tension, nerve irritation, can send faulty sensory information up to your brain about your head position. It often goes along with neck pain and might be triggered by neck movements or even past trauma like whiplash. Physical therapy can often help a lot with this type.
And visual vertigo, what's that?
That's an interesting one. It's dizziness or unsteadiness that gets triggered by complex or moving visual environments. Think scrolling quickly on a screen, being in a busy supermarket aisle with lots of patterns, or watching fast-paced action movies.
Oh, yeah.
It seems to happen more in people who already have some underlying vulnerability in their balance system, maybe from a past vestibular injury or migraines. They become overly reliant on their vision for balance, and then complex visual input kind of overloads the system. And of course, you have more general medical things. Low blood sugar, thyroid disorders, hyperdehydration, even things like carbon monoxide poisoning or just plain alcohol intoxication can all disrupt balance systems and cause dizziness.
Mm-hmm.
Oh, and there's also something called disequilibrium. You see it's a lot, especially in older adults. Basically, people become unsteady because they're inactive, they lose conditioning, maybe they develop a fear of falling, which then makes them even less active. It's a real vicious cycle.
And finally, fainting or near fainting, syncope and presyncope. People might call it dizziness, but it's really its own category.
It absolutely is distinct. Syncope is actually losing consciousness briefly, while presyncope is that feeling you're about to faint. This is usually caused by a temporary drop in blood flow to the brain, often due to a cardiovascular reason. The symptoms are characteristic. Sudden lightheadedness, feeling warm, maybe sweating, nausea, vision dimming, or getting tunnel-like. And it typically happens when you're standing up.
Okay, wow. That is a huge list of potential causes. How on earth do doctors even begin to sort through all that?
It seems daunting, right? But the sources are really clear. The single most crucial diagnostic tool is getting a detailed patient history. It's all about the questions.
Right.
What exactly does the dizziness feel like? Describe it. When did it start? How long did the episodes last? Seconds, minutes, hours, days? Is it constant? What brings it on? Head movement, standing up, stress, busy environments? And critically, are there any other symptoms happening at the same time? Hearing changes, headache, weakness, numbness. That initial story provides the essential clues. It's like detective work.
So really listening closely to how someone describes their experience is paramount. What about the physical exam itself?
A thorough physical exam, including a detailed neurological check, is essential. Doctors are looking for any signs that might suggest a central cause, problems with coordination, eye movements, speech, strength, reflexes.
Okay.
But as the sources caution, especially early on in something like a stroke, the neurological exam might seem normal. So a normal exam doesn't completely rule out a central problem right away, and then there are specific bedside tests focused on the vestibular system.
Like that Dix-Hallpike test you sometimes see pictures of.
Exactly. That's the go-to test specifically for BPPV. The doctor carefully moves you from sitting to lying back quickly, with your head turned to one side and slightly extended. The idea is to deliberately trigger those crystals to move in the suspected semicircular canal. If you have BPPV in that canal, this maneuver should provoke that characteristic short burst of vertigo, and the doctor will look for very specific involuntary, jumpy eye movements, nystagmus, that confirm the diagnosis and even tell them which ear and which canal is affected.
Fascinating. And what about the head impulse test?
The HINTS exam component.
Hmm.
This is a really valuable test, especially when someone has acute ongoing vertigo, to help tell peripheral causes, like vestibular neuritis, apart from central causes, like stroke.
Okay, how does that work?
The doctor has you focus your eyes on their nose. Then they give your head very quick, small, unpredictable turns to the side. If your peripheral vestibular system on that side is working properly, your eyes will automatically stay locked on the target. But if that peripheral system is damaged, like in vestibular neuritis, when your head is turned quickly towards the affected side, your eyes will actually get dragged along with the head movement for a split second off the target. Then you'll have to make a quick corrective eye movement, called a saccade, back to the target. Seeing that corrective saccade points towards a peripheral problem.
Okay, that makes sense.
But here's the really critical, somewhat counterintuitive part. If someone has severe, ongoing vertigo, and their head impulse test is normal, meaning their eyes stay perfectly locked on target during the quick head turns, that can actually be a red flag suggesting a central cause, like a stroke.
Wait, so a normal test can be the concerning sign in that specific situation?
Exactly, because if the severe vertigo were coming from the peripheral system, that system should be impaired and the test should be abnormal, show the catch-up saccade. A normal test in the face of severe continuous vertigo suggests the peripheral system is intact, so the problem might be originating higher up, in the brainstem or cerebellum. It's part of a cluster of signs doctors look for, called the Hints exam.
Wow, okay. That's really complex clinical reasoning. What about scans? CTs, MRIs, are they always needed?
The sources are pretty consistent on this. Routine imaging is generally not necessary for what seems like typical, straightforward peripheral vertigo.
Hmm.
If someone has classic BPPV symptoms and a positive Dix-Hallpike, or clear signs of vestibular neuritis that are improving as expected, you usually don't need a scan.
Okay.
Imaging is definitely indicated, however, if the history or the exam raises suspicion for a central cause, if the person has significant stroke risk factors, if they have other neurological symptoms alongside the dizziness, or if they have a new severe headache that started with the vertigo.
So use imaging selectively when the clues point towards something potentially more serious in the brain.
Precisely. And again, remembering that limitation, an early MRI might not catch everything immediately. Other tests might come into play too, depending on the suspected cause, maybe an EKG if fainting, syncope seems likely, blood tests for sugar, thyroid, vitamins, or a hearing test, audiometry, if there's hearing loss involved, like in Meniere's.
So once a likely cause is identified, how does the treatment approach vary? It must depend entirely on the diagnosis.
Completely. Treatment is absolutely cause-specific. The sources tend to group treatments into roughly 3 categories. Treatments that address the specific underlying disease.
Right.
Treatments just aimed at relieving the acute symptoms, like the intense spinning or nausea. And then therapies focused on promoting long-term recovery and adaptation, which is rehabilitation.
Okay, let's take BPPV first. You said the cause was mechanical loose crystals, so the treatment is mechanical too.
It is. It's actually quite elegant. For BPPV, these specific repositioning maneuvers, the Epley maneuver is the most well-known, but there are others for different canals are often curative.
How do they work?
They involve a sequence of specific head and body movements. The goal is to use gravity to gently tumble those loose crystals out of the semicircular canal where they're causing trouble and back into a different part of the inner ear where they belong and won't cause symptoms. It's like physically resetting the inner ear. Yeah. And the sources also mention some evidence, particularly for older women who are vitamin D deficient, that taking vitamin D supplements might help reduce the chance of BPPV coming back.
Interesting. What about for vestibular neuritis, that inflammation?
That's trickier acutely. The sources say that using corticosteroids early on, within the first few days, might help speed up recovery of vestibular function, but the evidence isn't totally definitive on long-term benefits. There's no single consensus on the best treatment right at the start, but often the focus is on managing the severe nausea and vomiting.
And Meniere's disease with those recurring attacks.
Meniere's treatment is complex and multifaceted. For the acute attacks, it's often similar symptom relief as for neuritis. Preventing future attacks is the main challenge. Options might include medications like beta-histine, sometimes diuretics or steroids, oral or injected into the ear. In really difficult cases affecting only one ear, doctors might consider treatments that intentionally reduce function in the affected ear, like injections of an antibiotic called gentamicin directly into the ear. But that's done cautiously, as it can have side effects. Lifestyle advice, like a low-sodium diet, is often recommended, although the sources note the supporting evidence for diet is actually quite limited.
For vestibular migraine, would the treatment mirror regular migraine treatment?
Pretty much, yes. Lifestyle strategies are key things like regular sleep, consistent meals, managing stress, regular exercise, and then standard migraine preventive medication or acute treatments are often very effective for the vestibular symptoms too.
What if the cause is something like orthostatic hypotension or POTS?
For those, the focus is often on lifestyle changes first. Making sure you're well hydrated, avoiding sudden changes in posture, maybe increasing salt intake under medical guidance, using compression stockings, Avoiding medications that might make it worse is also key.
Yeah.
Sometimes medications are needed to help support blood pressure or control heart rate. And exercise programs, especially structured ones, are really important, particularly for POTS management.
And if it turns out a medication was the culprit?
Well, that's often the most straightforward fix. If it's medically safe to do so, stopping or switching the offending medication usually resolves the dizziness.
Makes sense. And for the neck-related dizziness or that disuse, disequilibrium from inactivity?
Physical therapy is really the star here. For cervicogenic dizziness, therapy can address the neck mechanics and sensory input issues. For disuse disequilibrium, it's all about exercises to improve strength, balance, gait, and importantly, confidence to break that cycle of inactivity and fear.
You mentioned relieving acute symptoms as a category. What helps with that horrible spinning and nausea when it first hits hard?
Yeah, for severe acute vertigo, medications known as vestibular suppressants, things like meclizine or dimenhydrinate, can help calm down the intense spinning sensation. And anti-nausea medications, or antiemetics like ondansetron, can help manage the vomiting.
That sounds essential for getting through the worst of it. But the sources had a really important warning about using those symptom relievers, didn't they?
Yes, this is absolutely critical and something the sources emphasize strongly. These medications that suppress the vestibular system or nausea should generally only be used for a very short period, like just the first day or maybe two, during a really severe acute attack.
Why only short term?
Because, and this is the crucial insight, prolonged use of these suppressing medications can actually slow down or prevent your brain's natural ability to adapt and compensate for the underlying balance problem.
Oh, wow.
Yeah, your brain needs to sense the mismatch and learn to recalibrate, using input from your eyes and your body sense, proprioception, to make up for the faulty signals from the inner ear or vestibular nerve. These drugs basically mask the problem and stop the brain from doing that essential learning process, so they can hinder long-term recovery if used for too long.
So they're a temporary Band-Aid, but you need to take the Band-Aid off quickly so the real healing and adaptation can happen.
Exactly, which leads perfectly into that third category of treatment, promoting recovery through vestibular rehabilitation therapy, or VRT.
This involves specific exercises, right, tailored to the person.
Precisely. VRT is based on the brain's amazing ability to change and adapt neuroplasticity. If one part of the balance system isn't working right, VRT uses specific exercises to train the brain to rely more on the other senses, vision, proprioception, and to recalibrate the remaining vestibular function.
What kinds of exercises?
It varies, but often includes things like gaze stability exercises, learning to keep your eyes focused while your head moves, habituation exercises to gradually reduce sensitivity to movements or environments that trigger dizziness, and balance and gait training to improve stability and confidence when walking or standing.
And does it work? Is there good evidence?
Yes, the evidence base for VRT is very strong. The sources consistently highlight its effectiveness, especially for ongoing dizziness after peripheral problems like neuritis, for chronic dizziness, for disuse disequilibrium, and even for helping people compensate after central nervous system issues or if they have balance loss in both ears. It's particularly vital for older adults to combat that fear of falling and get them moving safely again.
Looking back at everything we've covered, it's just staggering how much can be behind that one simple word, dizziness.
It really is. It's a symptom with just a huge range of possible explanations. Understanding precisely what a person is feeling, that spinning versus lightheadedness versus unsteadiness and the timing, the triggers, that's the absolutely essential first step in narrowing down the possibilities.
Followed by that careful exam and using tests or imaging smartly, only when needed.
Exactly. And I think the big takeaway from digging into these sources is that while treating the acute, severe symptoms is important right at the start, the real key to getting better long-term is often less about just suppressing the dizziness and more about figuring out the root cause, addressing that, and then actively engaging in things that help your brain adapt and recover, with vestibular rehab being a prime example of that.
It's about working with your brain's ability to compensate, not against it.
Well said.
So here's something to think about. That sense of balance, of just feeling stable and oriented in space, is something we totally take for granted most of the time. But it relies on this incredibly complex moment-by-moment collaboration between our inner ears sensing motion and gravity, our eyes mapping the visual world, feedback from our muscles and joints telling our brain where our body parts are, and then our brainstem and cerebellum weaving it all together instantly. When just one instrument in that intricate orchestra is off-key, it can create that profoundly disturbing sensation of dizziness. It really gives you a new appreciation for just how finely tuned our bodies are to navigate the world around us.